Hi, my name is Larissa Pisney. I'm the medical director for infection prevention for the metro region of UCHealth. I'm also an associate professor in the Division of Infectious Diseases at the University of Colorado Anschutz School of Medicine. And today I'll be speaking to you about the management of the patient exposed to Yersinia pestis in the setting of a bioterror attack. I have no conflict of interest to disclose. And so just to go over our agenda real quickly today, we'll be starting with the background on Yersinia pestis, including the epidemiology of plague, reviewing the clinical presentation and diagnosis, going over treatment, including both pre and post-exposure prophylaxis, and then lastly, talking a little bit about surveillance, detection, and containment. So plague is caused by Yersinia pestis, which is a zoonotic bacteria usually found in small animals and their fleas. It is a non-modal gram-negative coccobacillus bacteria that doesn't develop spores. Certainly, it wouldn't be a good infectious disease doctor if I didn't talk about the characteristics of the bacteria itself. And humans are incidental hosts that do not contribute to the natural disease cycle. There are three major clinical manifestations: bubonic, septicemic, and pneumonic plague, but there are some other manifestations that have been described as well, and incubation is usually 1 to 7 days. The World Health Organization reports about 1,000 to 3,000 cases of plague worldwide every year. And in the United States, on average, 7 human cases have been reported. The range has been about 1 to 17 over the last period of time. And then in terms of transmission to humans, most often transmitted by the bite of an infected flea. It can also be spread by direct contact with infected tissues or bodily fluids of a plague-infected animal. This also includes scratches or bites from infected domestic animals such as cats. And it can also be spread by consumption of inadequately cooked meat from infected animals. And then the form that we really would think about in the context of this talk is inhalation of aerosolized droplets from an animal or human with pneumonic plague, or that was deliberately spread. Plague is spread by large respiratory droplets that do not remain suspended in the air for a prolonged period of time. And then there are healthcare exposures that can occur either during postmortem examination or laboratory handling or testing. Okay. So Yersinia pestis as a bioweapon is possible because the bacteria occurs in nature and could be isolated and grown in the laboratory. It is important to note that managing or manufacturing an effective weapon using Yersinia pestis would require advanced knowledge and technology. It is a tier 1 bioterrorism select agent. This category includes other agents like anthrax and smallpox. And the reason it has this designation is because it has a low infectious dose and can be transmitted person to person. It also has a high case fatality rate if left untreated, which has the potential for a major public health impact as well as social disruption and panic. And there's also a history of it being used as an agent of bioterrorism. The most classic examples are, much older, using plague-infested corpses or fleas. In terms of use as a bioterrorism agent, it would most likely be used in aerosol attack causing pneumonic plague. This would be the spread of tiny particles or droplets containing Yersinia pestis being released into the air in dust, mists, or fumes. The WHO estimates that if 50 kilograms of Yersinia pestis was released in the air over a city of 5 million people, this could result in 150,000 cases of pneumonic plague and 36,000 deaths. Due to the fact this bacteria has an incubation period and outside of the normal geographic context, diagnosis would likely be delayed because presentation can be relatively nonspecific. individuals could unknowingly infect those around them. The basic reproductive number, or R0, which is the average number of secondary cases per case, has been predicted to be 1.18 for pneumonic plague. However, it's really important to note that there's a high variability in the transmission potential from individual patients, and that patients are more likely to infect additional individuals the further their disease progresses. Another component that would make it hard to control is that animals in the area could also be infected, resulting in a local epizootic and then subsequently cases of bubonic plague. And so it could be very difficult to control an outbreak in this situation. So in terms of a case definition for plague, one of the elements that can be used is epidemiologic linkage. So we've already gone over a lot of this, but what is included in that case definition that's used by public health is a person that was epidemiologic to a person or an animal with confirmed laboratory evidence of an infection with Yersinia pestis in the last 2 weeks. A person that has had close contact with a confirmed pneumonic plague case, including but not limited to presence within 2 meters or 6 feet of that person while they had a cough, ultimately found to be due to pneumonic plague. And then lastly, a person that lives in or has traveled within 2 weeks of illness onset to a geographic area where confirmed plague epizootic activity in fleas or animals is known to be present as determined by the relevant local authorities. So in terms of clinical presentation, the most common form is bubonic plague. And so this is typically the result of the bite of an infected flea. And this is when patients present with a febrile lymphadenitis. Patients, so what this means is they come in with swollen or painful lymph nodes and associated edema and erythema. These lymph nodes are called buboes, and they occur in the region that drains the inoculation site, or the place where the flea bit the individual. So common areas include inguinal, epitrochlear, axillary, and cervical. Particularly large or suppurative buboes may warrant incision and drainage. Bubo is actually derived from the Greek word for groin. And as I said, bubonic plague is the majority of cases, about 80 to 95%. But if untreated, at least 50% of cases will then progress to disseminated infection. The next form I want to talk about is septicemic plague. So this can occur in one of 2 ways. It can either be the first symptom of plague or may develop as a result of untreated bubonic plague. So this is very nonspecific and requires a high level of clinical suspicion to make the diagnosis. So it can be a febrile illness that doesn't have any localizing signs or symptoms. Patients can have GI symptoms, including nausea, vomiting, diarrhea, and abdominal pain. It can progress to a life-threatening illness with shock, DIC, bleeding, and multi-organ failure. And oftentimes patients will develop purpuric skin lesions on their extremities or trunk, or gangrene of their distal extremities. So you can see with this very non-specific collection of symptoms that it could be very hard to diagnose. And then pneumonic plague, which is the kind that we would think about most commonly in the setting of a potential bioterrorism event, can be primary or secondary. So primary pneumonic plague is acquired by inhalation of respiratory secretions or aerosolized droplets from infected animals or humans. It can also occur in the lab. And then secondary pneumonic plague is also common and more common than primary, and arises via hematogenous spread of bacteria from a bubo or other source. And so while the typical incubation period is 1 to 7 or 1 to 8 days, for primary pneumonic plague, the incubation period is often 1 to 3 days. And patients, again, can have a relatively non-specific presentation with high fever, headache, weakness, a rapidly developing pneumonia with shortness of breath, pleuritic chest pain, and a cough that's sort of classically bloody sputum, but could also be purulent sputum. And this is the only form of plague that can be spread person to person via droplet transmission. There are also less common manifestations of plague, both pharyngeal and meningeal. Also in larger case series, both GU and GI involvement have been described. And when we think about the diagnosis of plague in an epidemiologic perspective or a public health perspective, cases are defined as suspect, probable, or confirmed based on a combination of clinical presentation, laboratory results, and or epidemiologic linkage. And again, you must have a high index of suspicion to be able to make the diagnosis for both septicemic and pneumonic plague. And we'll talk a little bit later about why it's so important to make the diagnosis early, as well as start patients on treatment early. So really quickly, in terms of epidemiologic linkage, so in the context of public health diagnosis, this is a person that's epidemiologically linked to either a person or an animal with a confirmed case by laboratory evidence in the last 2 weeks. And so it can also be close contact with a confirmed pneumonic plague case. And that's, we look at individuals within a period of space of 2 meters or 6 feet. And that person, if by history has an active cough due to pneumonic plague, a person that lives in or has traveled within 2 weeks of illness onset to a geographically localized area where there's confirmed epizootic activity in fleas or animals determined by the relevant local authorities. So what essentially, this is just pulled directly from a case definition. And what I wanted to highlight is that, again, fever, hypotension, and unexplained regional lymphadenitis is very nonspecific. And so you have to think about the diagnosis in a person with contact with dead rodents or residents in or travel to an endemic area in the US. But again, this highlights how in a bioterrorism incident, it could be very easy to miss the diagnosis. In terms of laboratory findings, a leukocytosis with a white count greater than 20,000 or a thrombocytopenia are very common. It is important to note that Yersinia pestis grows well on routine laboratory media, including blood cultures and McConkey agar. It can be recovered from blood, sputum, CSF, or pus aspirated from buboes. Oftentimes patients will have a gram stain from respiratory cultures that shows gram-negative rods. And then classically, it's known for having this bipolar staining, which makes it look like a closed safety pin on certain types of stains that are used in the lab. Also very important to note that automated bacterial identification systems so that we oftentimes use in labs have been known to misclassify Yersinia pestis as Pseudomonas luteola, Acinetobacter, or Yersinia pseudotuberculosis. So if this is seen in the and it doesn't quite make sense with the clinical presentation, it's important to think about Yersinia pestis as a potential diagnosis and send that specimen on to the state health lab for help in terms of accurately identifying the cause. Also very important that when you're sending mycobacterial cultures from a patient with suspected plague, that you let your lab know so that they can take the appropriate precautions. And then in terms of confirmatory diagnosis, this can also be made via serology. A confirmatory diagnosis requires acute and convalescent serum, looking for at least a 4-fold rise in antibody titers to the F1 antigen of Yersinia pestis. And then rapid tests are available for use in resource-limited settings. And I just included this again very briefly. These are from the criteria to make a diagnosis of Yersinia plague. So presumptive evidence includes a single titer of greater than 1 to 16 by the same method discussed on the last slide, in a patient with no history of plague vaccination. So that would be suggestive of a diagnosis, and then detection of Yersinia pestis DNA or antigens on rapid diagnostics, so DFA, an immunohistochemical assay, or a PCR, and then confirmatory laboratory evidence is isolation by culture that has been validated by a secondary assay performed either by the CDC or the Laboratory Response Network. And then in terms of serology, a confirmatory diagnosis again would be that 4-fold or greater rise in paired serology. Imaging findings, very nonspecific. So chest radiography may demonstrate nonspecific disease processes such as nodular or patchy infiltrates, lobar pneumonia or pleural effusions. A potential clue to Yersinia pestis, though certainly not unique to this bacteria, is hilar or mediastinal adenopathy. And then in terms of if you're a healthcare worker taking care of someone with suspected or confirmed plague, these patients should be placed on droplet precautions until pneumonia has been ruled out and sputum cultures are negative. Airborne precautions are typically not necessary, but certainly are reasonable during aerosol generating procedures in patients with pneumonic plague. As we've certainly learned over the course of the last several years, droplet to airborne does occur across the spectrum, and even organisms that are typically thought of as droplet can potentially be aerosolized during these types of procedures. And then for those that have pneumonic plague, droplet precaution should be continued until antibiotics have been given for at least 48 hours and there is evidence of clinical improvement with markedly decreased sputum production. Also important to note, as a part of just standard precautions, in addition to a mask, eye protection or a face shield is suggested for any procedure that could result in splashes of bodily fluids, such as a bubo aspiration. So treatment, and I just want to say here that we will include at the end of the YouTube, we'll include an attachment with tables. The guidelines regarding treatment of plague are very dense, but I did want to touch on sort of the high points in terms of classes of antibiotics used for treatment. So we'd say classically aminoglycosides, fluoroquinolones, and tetracyclines are all first-line agents. And then even within those classes, there are agents that are preferred over others, but there are many options for treatment. So for aminoglycosides, the agents that we typically use are gentamicin or streptomycin, which can be given both either intravenously or intramuscularly. Typically, these are the agents that are used as first line because there's the greatest clinical experience and published knowledge around the use of these agents. But certain things could drive folks to use other antibiotics. So if there's increased concerns for nephro or ototoxicity, particularly in patients with advanced age, known kidney disease, or that are requiring other nephrotoxic agents, these might be avoided. And we'll talk a little bit more, just very high level, about the difference between efficacy of these agents. In terms of fluoroquinolones, the most common agents used are ciprofloxacin, levofloxacin, and moxifloxacin. These can be given IV or PO. In the guidelines, every agent that can be given orally can be administered via alternative enteral routes, such as a nasogastric tube or gastric tube, with the exception of ciprofloxacin. And so for fluoroquinolones, which obviously are a very common agent, adverse effects include QTC prolongation, neuropsychiatric disturbances, including dizziness and imbalance, but in some individuals more severe delirium, hypoglycemia, aortic rupture, and damage to connective tissues. But typically we don't think about those things unless patients on a very prolonged course. It's also important to note for children 3 months to 17 years, moxifloxacin is put down into the alternative category just because this agent has higher reported rates of QTC prolongation compared to other fluoroquinolones, and it's not FDA approved for use in children. In terms of tetracyclines, there are many agents that can be used. But doxycycline is the most common. This can be given both IV or PO. Other agents include just tetracycline, minocycline, eravacycline, or omadacycline. For doxycycline specifically, often not used in children because of concerns for tooth staining or enamel hypoplasia, though those have not been described in brief courses of doxycycline. If that's the agent that's available to you, certainly would not restrict its use in a patient with plague just because of that. And then alternative options for the treatment of plague that fall down into the alternative agents criteria include trimethoprim, sulfamethoxazole, or Bactrim, chloramphenicol, and then other agents in the same classes of antibiotics as the ones that I just discussed. So for aminoglycosides, this is agents like tobramycin, amikacin, and plizomycin. For fluoroquinolones, this includes gemifloxacin and ofloxacin. And tetracyclines, I've already discussed what those alternatives are. It is important to note that certainly Bactrim has several well-known side effects, including kidney injury, hyperkalemia, blood dyscrasias, drug-induced liver injury, and delayed hypersensitivity reactions. The other thing that can oftentimes be rate limiting in terms of using Bactrim in patients with a respiratory process is that it does have a large amount of carrier fluid, and that oftentimes in these patients that are having significant respiratory failure, we want to limit the volume of fluid that they're getting. And then chloramphenicol can be associated with serious and fatal blood dyscrasias. So in most instances, natural occurring infections from Yersinia pestis do not require dual therapy, but dual therapy is required in some instances. So the most important one and pertinent to this talk is in the event of bioterrorism. It is recommended to give 2 agents until susceptibility testing has been performed due to the possibility of engineered resistance. Other instances where 2 agents may be used are patients with large buboes or severe pneumonic plague or septicemic plague. And then some of these instances I'll talk about here under special situations. So pharyngeal plague is treated the same as bubonic plague. Meningeal plague is treated with a combination of therapy with chloramphenicol and either levofloxacin or moxifloxacin, and these agents are preferred to others because of their higher penetration into the cerebrospinal fluid. And then for infection during pregnancy, a combination of agents is also recommended. So typically gentamicin and either ciprofloxacin or levofloxacin. And this is because of the high potential for maternal morbidity, the possibility of perinatal transmission, and then also the potential for increased drug clearance that can occur during pregnancy, which may require higher than usual doses. I will say it's important to note that in pregnancy, one of the most common agents that we use, streptomycin, is contraindicated. And then a few more sort of final points in terms of treatment of disease. The optimal duration of antimicrobial therapy is not clear, but the CDC recommends at least 10 to 14 days of therapy. This may be prolonged if a patient is slow to respond. And then in terms of access to these agents, so these are, as you can see, many of them common agents that are used every day. So typically we should have access to them. I would say in terms of dosing, it is helpful to have a pharmacist to help you dose the aminoglycosides, for example. But in the instance of a large outbreak, it's important to note that medical countermeasures or MCMs are maintained in the Strategic National Stockpile for use during public health emergencies, and can also be deployed for individual cases or small outbreaks if necessary. These MCMs can be sent anywhere in the United States within a period of 12 hours. I think it's very important to highlight just how deadly this illness can be. So the case fatality rate for untreated plague, there's wide ranges in the literature, and it can vary by presentation, but ranges from 60 to 100%. And in particular, pneumonic plague can be rapidly fatal within 18 to 24 hours if individuals are not started on appropriate treatment early. In one of the largest systematic reviews published of 762 cases of plague, case fatality rates for patients that were placed on treatment, and this is all comers, was 17% for bubonic plague, 27% for pneumonic plague, and 38% for septicemic plague. It is important to note within those case fatality rates, what they went to do in this paper was then further separated it out and categorized it into those who were treated either 3 days or more after symptom onset, or those who were treated within 2 days. And what you can see here is that the case fatality rate was 24 versus 9% for pneumonic plague, 33 versus 20%, or sorry, 24 versus 9% for bubonic plague, 33 versus 20% for pneumonic plague, and 56 versus 18% for septicemic plague. What this really highlights is that early diagnosis and treatment are essential for survival and reduction of complications. This paper did go on to look at case fatality rates across agents used and what they were able to show. But again, this is about, slightly over between 700 and 800 patients. Case fatality rates were similar for patients that were treated with aminoglycosides, fluoroquinolones, or tetracyclines. Case fatality rates for patients treated with sulfonamides was slightly higher, but they noted in the paper that this could have been affected by a time period bias. In terms of prophylaxis, pre-exposure prophylaxis is not considered necessary as long as standard and droplet precautions can be maintained while taking care of patients with plague. In crisis settings with potential surgical mask shortages, patient overcrowding, and poor ventilation in hospital wards, pre-exposure prophylaxis with the agents listed below may be reasonable for healthcare providers and first responders if supplies of said agents are felt to be sufficient. And then in terms of optimal duration, it's not entirely clear, but if initiated, pre-exposure prophylaxis can be discontinued at 48 hours after the last known exposure. Post-exposure prophylaxis is recommended for individuals who have had unprotected face-to-face contact within 6 feet of patients with known or suspected pneumonic plague, who have not received at least 48 hours of effective therapy. And so what you'll see here is that these agents are, the ones that we just went over. And so I've included the doses here, but doxycycline orally, ciprofloxacin orally, and also levofloxacin and moxifloxacin orally. Generally, post-exposure prophylaxis is given for at least 7 days. And then lastly, just to note, a killed whole cell vaccine has been developed, but is no longer commercially available in the United States, and data on the efficacy of this vaccine is limited. And then just a few things I wanted to go over as a hospital epidemiologist and work that happens behind the scenes all the time. So in addition to preparedness activities, one thing that's done, routinely again behind the scenes is surveillance for this agent and others, and then important to really think about that timely diagnosis. So it is required that plague be reportable to state public health within 4 hours of a suspected diagnosis, and it is also nationally reportable. It's also very important that confirmation occurs. So this is why the isolates are either sent to state public health labs, including the Laboratory Response Network. So submission of isolates or clinic material to public health within 1 working day is required for this confirmatory testing, and then also susceptibility testing, which, as we highlighted previously, is very important in the instance of a bioterrorism event. Case detection. So we've already talked about how cases are defined as suspect, probable, or confirmed based on a combination of clinical information, laboratory results, and or epidemiologic linkage. And so questions that an infected individual may be asked to aid with epidemiologic investigation include symptoms such as cough or respiratory symptoms and the timing of those, anyone with whom they know they had close contact, so again, less than that 6 feet for a sustained period of time following their development of cough, and then detailed information about the places that that person visited after the onset of their cough to help determine what additional individuals may have been exposed. And then local, state, and national health agencies will aid in the investigation and containment. And very briefly, I wanted to go over, what all that would entail. So support in terms of medical management for possible and confirmed cases. Public health would ensure the availability of medical supplies, devices, and equipment. It would also help run disease control, including directed prophylaxis. So this oftentimes includes a risk stratification and development of eligibility criteria for receipt of prophylaxis among individuals. And so many factors are taken into account, but these include the nature and the extent of the incident, what resources are available, and it's important to think about this in the context of an ethical framework. Also, public health would work to conduct an epidemiologic analysis to identify the most likely exposure and identify unexpected features of the outbreak. And then they would also estimate the population at risk and ensure rapid identification and reporting of additional cases. There would be a lot of work done behind the scenes to characterize the outbreak itself and the extent to develop the most appropriate containment strategies. Also, as we touched on very briefly, important to identify possible infected animal populations and where environmental evaluation and remediation may be necessary. And then lastly, in any outbreak or public health emergency, public health would also help in terms of communication strategies to make sure that the public is informed and limit terrorists' ability to induce public panic or disrupt daily life. So I have several resources listed here. I think the most important one to highlight is, first of all, there's many resources on the CDC and WHO websites, but this MMWR, second from the bottom, the antimicrobial treatment and prophylaxis of plague, again, is very dense and has a lot of great information in it. And we'll make sure that we've pulled out some of the tables to put at the end of this YouTube. And then if you have any questions, the email for the Mountain Plains Regional Disaster Health Response System is included here, as well as my work email.